Thank you. So I would like to present about the stem cell and tissue engineering for repair, restore, regeneration, and replacement. Ini tolong, kalau nggak jalan ya. Ini ya. Okay. Thank you. The stem cell and tissue engineering is directed for repair, replace, restore, and regenerate. And recently, is directed for the rejuvenation. If we divide it to the approaching of the stem cell and tissue engineering, if in the tissue engineering approach base, so it means we would like to do the replacing the structures. But if the approaching for the cell-based therapy, it means the direction is the replacing of the metabolism. And if we divide it according to the endogenous and exogenous, the stem cell treatment, so the stem cell treatment can achieve by endogenous stem cell. It means we mobilize the stem cell from the patient itself, from the patient body. So we add the substance, some kind of substance, so we can facilitate the stem cell to mobilize by the protein stimulation, exercise, and etc. But the limitation is depend on the patient condition. And the other way is we adding the exogenous stem cell from outside of the body. We can divide it into the cell-based or tissue engineering with the application from topical, IV, systemic, or directly to the target tissue or organ. And if according to the effects, the stem cell giving the effects to our body by several pathways, from the endocrine effects or immunological effects, by lymphatic tissue or injury site, and also the direct effects. Yeah, if we put something to the, for instance, to the gaps of the bone defects gaps, by transdifferentiation and regeneration, or maybe by paracrine effects. The stem cell stimulate the surrounding stem cell to do the proliferation. Again, if the tissue engineering that mentioned by previous speakers consists of the cell scaffold as the osteoconductors and the signaling molecule as the osteoinductive stimuli, but the most important thing with the timing and with the appropriate of the environment, with the microenvironment, with the niche, it will stimulate regeneration of the tissue or maybe the organ. The first example in the bone engineering with the tissue engineering triad. For the cell, for instance, we can use adult mesenchymal stem cell. In our centers, we would like to become mecca of the adult mesenchymal stem cell. We don't use the embryonic stem cell. If the mesenchymal stem cell, the source is from adipose, bone marrow, and also the umbilical cord. And for the scaffold, we use for instance, hydroxyapatite. And then number 3, signaling molecule. For the bone, most of the growth factor that we use is BMP2 or PRP. The first principle, the cell. The cell, for instance, is osteogenic progenitor cell, osteoblast, or adult mesenchymal stem cell. And the second principle, the osteoconduction the fact must be filled with the scaffold that mentioned by Dr. Deki. The scaffold should be biocompatible, should be facilitate cell growth. In this case, the cell growth is from the mesenchymal stem cell, grow and differentiate into the osteoblast. So we need, for instance, hydroxyapatite, calcium sulfate, and others. And the third principle, we need growth factors, osteoinduction, as the osteoinduction. BMP2, VEGF, BDGF, FGF, or IGF. The first projects, for instance, I show you the case in the critical size bone defects. What does it mean by critical size bone defect? Is more than 1.5 until 2 times diameters of the long bone. So usually more than 5 centimeters, the defects. In the bone, we added with the mechanical environment. So the concept, tissue engineering triad plus mechanical environment or mechanical stabilization, we call it as diamond concept. This is the flow. So after we do the isolation, aspiration from, for instance, from the bone marrow, from the iliac crest, we do the isolation and then proliferation cultures. And in the step we have, of course, we do the sterility testing. This is the expansion after the 3 or 4 weeks, after the cell is confluent in the tissue flash. And then we characterize whether the cell is really mesenchymal stem cell according to the International Society for Cell Therapy. One of that is number 1, spindle-shaped like cell, either in the tissue flash. Number 2, differentiate into the osteogenesis, chondrogenesis, and adipogenesis. And number 3, characterize. Should be the CD105-73 positive, more than 95%, and negative for the CD14, 19, 34, or 45. And we do the sterility testing from the bacteria, microorganism, and mycoplasma. At the end of the first week and before cell transplantation. This 9 cases so far, we do the treated with the stabilization, autogenic mesenchymal stem cell, hydroxyapatite, and BMP2. And we evaluated with the subjective measurement and objective measurement. Subjective with the lower extremity functional score, DAS score, and objectively by radiological scoring. This is the pictures, the result, according to the visual analysis scale, lower extremity functional outcome, and defect volume, Tiedemann score, all of that, all the X cases, statistically significant improve. And this is the pictures of the cases before and after we do the treatment to treat the bone defects at least more than 5 centimeters. The picture, the case number 1. This is the 8 years osteofibrous dysplasia with a tumor, bone tumor in the lower legs. So we have to do the resection to remove the tumors. So removing the tumor, leaving the gaps. So we have to do the lengthening as well, fill the defects with the hydroxyapatite, BMP2, and autogenic mesenchymal stem cell. We treat it with the 50 million mesenchymal stem cell. This is the pictures. This is 41 weeks after the treatment. The patient still limping because of still using the Joko Sarov external physician in the outpatient. And then after 1 week, this 1 week after we remove the external physician. And this and the follow-up 1 year 9 months in the outpatient clinics, the patient can walk quite normal. I mean normally. And then the patient can stare down, and also the runnings. And finally, the patient can play football again. And we have already published this the case report, because to our knowledge, this is the first report for combining treatment using bone marrow mesenchymal stem cell, hydroxyapatite, and BMP2 for treating bone defect in human subjects. We know that there are so many available options to treat the bone defects like vascular autograft, muscular technique, Papino procedures, bone transport, but all of that have the disadvantage. Maybe, for instance, result the joint stiffness or take longer time, or maybe not adequate enough for in the strength of the bone. And and with the exogenous mesenchymal stem cell for the bone defects, I think the effects mostly or predominantly because of the exogenous mesenchymal stem cell that we implanted, could stimulate also those dormant mesenchymal stem cell as the paracrine effects, and while in bone defects, more prominent its direct effects. MSC in those defects proliferate and differentiate into the osteogenic cell. The conclusion of these projects, MSC substitute the major meshing component in the critical bone size defects, and additional BMP2 in the bone marrow mesenchymal stem cell and hydroxyapatite and mechanical stabilization improve clinical size bone defect clinically and radiologically less than 1 year. And this combination remain to be good candidate for the definitive in the neglected difficult fractures for the union or in the critical size bone defects. And number 2, replacement. We replace the diseased tissue with the stem cell will grow and develop to be renewable tissue, such as skin and neural cell. In our setting, we have done research in the integumentary tissue like bone wound, neural tissue for the spinal cord injury, and bone tissue. And number 3 is rejuvenation. Rejuvenation is the strategy of to self-renewal of the tissue that promote tissue healing. Naturally, the resident of the stem cell enable to recycle the senescent cell to be younger cell. So in rejuvenation, ensure the continuous production of the renewable tissue required for the long-term tolerance due to the tissue injury. And the second project for the cartilage, to repair, regenerate, restore, and replace for osteochondralization and osteoarthritis. As you know, the osteoarthritis is the joint pain and dysfunction. The most important thing, there is articular cartilage thinning, and there is process of the remodeling and sclerosis of the subchondral bone, and result to the deformity, usually genivarus or genivalgus, like this, usually arising from the osteochondral lesion, defects, ulcers in the cartilage. We don't want this osteochondral lesion become osteoarthritis, like this. Because if osteoarthritis, usually in the end states, usually will produce the deformation, varus or valgus. And we take the X-ray like this from the lateral view, and in the past or right now, the standard of the treatment is replacing by total knee replacement. So that's why we would like to do the projects. How to prevent the osteochondralization and then progressively become osteoarthritis. As you know, the arthroscopic microfractures and mesenchymal stem cell injection, according to our projects, we can see from the pictures, the isolation here, this before the stem cell implantation and this after. We can see in the MRI, there is improvement. Yeah, there is improvement in the cartilage regeneration. This arthroscopically. Before there is ulcers of fissuration or fibrillation. Again, this one is follow up in the 6 month. We can see very well. This is the white appearance. Before there is dark or black appearance. And in other study by Basuki reported that microfractures deep in the osteochondral defects were not given significant difference. And so there is no difference between microfractures and without microfractures. And according to the Mokbel study, in the osteoarthritis, clearly show evidence of the ongoing inflammation. So that's why in our second project, we did not use arthroscopic techniques to do the microfractures, and then we directly implanted the mesenchymal stem cell using umbilical cord stem cell by intraarticular injection. Why we can use the allogenic mesenchymal stem cell? I mean, we confident with the allogenic mesenchymal stem cell because theoretically allogenic is mesenchymal stem cell relatively low immune the HLA type 2. Immunorejection usually is HLA type 1. And the second one, undifferentiated and differentiated mesenchymal stem cell do not elicit alloreactive lymphocyte proliferative response and modulate immune response. And MSC is hypoemogenic and suppress T cell alloproliferation in mixed lymphocyte reaction. And number 4, MSC avoid allogenic rejection because the lacking major histocompatibility complex type 2 disrupt natural killer cell CD8 and CD4, produce prostaglandin, interleukin 1, interleukin 10, and express in indoxyindolamine 2,3 deoxygenase that induce the suppressive local microenvironment. So the same protocol, the difference is we can do the cryopreservation. After we isolate and proliferate the stem cell, we preserve in the cryopreservation. Whenever we need it, so we do the thawing and then do the implantation. This is the evaluation. This is the pictures of the patient. So far, there are 10 patients. Actually, now is already 26. I mean, this 20 patient that has already evaluated at least 1 year. This is the picture. We use the cartogram. In the cartogram, we can see if there is softening or thinning of the cartilage. Usually, deep thinning become red, and moderate thinning yellow, and the good one is green. We can see in the 6 month there is improvement from red to yellow or yellow to the green. We can see, and we can calculate the numbers whether the cartogram is improved or not. This is the pictures before and after we do the cartogram. And according to the statistically is significant in terms of functional art scale, IDQ score, WOMAC, and T2 value. And the next one is the skin for the burn wound. See, the stem cell management for the wound enhance the wound healing, facilitate skin regeneration. This is the pictures before and after. Usually the burn wound usually takes 3 months, but using the mesenchymal stem cell allogenically, of course allogenically because the patient is gravely ill, so it take only 26 days to do the rehabilitation. And the last one is spinal cord injury. The spinal cord injury is also the non-option treatment because usually the patient is paralyzed, cannot, there is sensoric and motoric problems. We can see here the pictures of the patient. And according to our temporary result, there is improvement in the muscle mass, in erectile function, in ejaculation, and sensoric. Before the patient have neuropathic pain. After we do the implantation of the stem cell, usually the pain is alleviated, and the motoric movement is still mild. We can see here the picture. The patient usually previously cannot zero. The motoric is 0, but now the patient can move. And also the most important thing, the patient usually the fathers or the husband is complain, but after the erection improvement, the wife complain. And then this another case. The patient previously also again 0, the motoric function is 0, and also the problem with the defecation, with the urination, micturition. And now after we do the treatment, although the patient not normal to the 5, the patient with the facilitation with the brace, actually the patient can stand. The transplantation of the stem cell will support spinal cord repair. Stem cell could differentiate into the neuron, glia in vitro, and enhance axon regeneration. And lastly, with the tendon, with the tendon engineering, usually we do the defects for the tendon in the supraspinatus full thickness tear, or in the nerve, for instance, the sciatic nerve injury. This is done by our colleagues in Surabaya. And as summary, the stem cell and tissue engineering directed for the restore, regenerate, and repair, replace, and rejuvenation. And cell-based therapy is directed to replace metabolism, and tissue engineering is to replace structures. And for the bone and cartilage, this stem cell rebuild injury and secrete growth factors for enhanced tissue regeneration. And in the bone, we need diamond concept. And for the cartilage, usually the stem cell could to do the regeneration, repair, and replacement. And allogenic umbilical cord mesenchymal stem cell for the osteoarthritis is an alternative method in the treating early stage of the osteoarthritis. And for the bone wound, this stem cell show hastening of the tissue reepitheliation process. And for the damaged spinal cord injury, this stem cell improve especially in the sensoric and autonomic function recovery, and mild for the motoric improvement. And for the tendon and also the nerve, this stem cell regenerated tendon has the temporal effects with the greatest efficacy during early phase of healing. Thank you.